Peptic ulcers. Peptic ulcers, broadly defined as the ulcers that typically extend deeper into the muscularis mucosa of gastrointestinal tract. It much frequently occurs in upper gastrointestinal tract. 3 common forms of peptic ulcers. Helicobacter pylori positive peptic ulcers. It presents with a chronic form, mainly affects stomach and duodenum. Non-steroidal anti-inflammatory drugs, also called NSAIDs, induced peptic ulcers. It also presents with a chronic form. It affects stomach, duodenum. Stress-related mucosal damage, SRMD, manifests as mucosal lesions range from superficial gastritis and erosions to deep ulcers. Occasionally, ulcers develop in the esophagus, jejunum, ileum, or colon. The most important factors that influence ulcer recurrence are H. pylori infection and NSAID use. Other factors include cigarette smoking, alcohol use, ulcer-related complications, gastric acid hypersecretion, and patient non-compliance. So, widely the cause of peptic ulcer recurrence is multifactorial. Other typical conditions include Zollinger-Ellison syndrome, zoonosis gastronomus, which means one or more tumors develops in the GI, produces massive amounts of gastrin, eventually leading to produce much acid from the stomach. Radiation, some sort of chemotherapy, vascular insufficiency, and other chronic diseases also associate with the disease. Recent trends have suggested and shown shift of predominance from men to similar occurrence in both men and women. Despite a modest decline in mortality, hospitalizations, and office visits, PUD remains one of the most common GI diseases, resulting in impaired quality of life, work loss, and high-cost medical care. It's thought and known that in most cases, PUD arises in the presence of acid in pepsin when H. pylori, NSAIDs, and other cofactors that disrupts the normal mucosal defense mechanism. H. pylori bacteria. H. pylori is a spiral-shaped gram-negative, microaerophilic bacterium that resides between the mucus layer and surface epithelial cells in the stomach, or any location where gastric epithelium is found. When an individual infected with H. pylori infection, it was stated that he will be affected with chronic gastritis, which causally linked or eventually developed to peptic ulcer disease. The prevalence of H. pylori varies by geographic location, socioeconomic conditions, ethnicity, age. An utmost prevalence of H. pylori infection is seen in the developing countries when compared to industrialized countries. H. pylori produces a massive amount of urease, which then hydrolyzes urea in the gastric secretions to carbon dioxide and ammonia. And this creates a neutral environment for the bacteria to sustain and infect, as it's considered to be pH sensitive. Yeah, it's right. H. pylori invasion produces ulcers. But how? Firstly, the mucosal injury, a significant event, occurs as the bacteria releases enzymes that are destructive in nature, namely, urease, lipases, and proteases. Adherence also plays a prominent role, in which H. pylori gets attached to the gastric epithelial cells by means of adherence pedestals. Lipases and proteases degrade gastric mucus. Ammonia produced due to urease attack easily uptaken to gastric epithelium, that even cause a higher toxic event to gastric epithelial cells. In response to invaded bacteria, host immune system produces an inflammatory response through sequential events, which results in the destruction of epithelial cells by cell-mediated immunity mechanisms or by phagocytosis. As stated previously, NSAIDs also shows a significant impact in developing peptic ulcers when compared to H. pylori. The 2 prominent mechanisms that NSAIDs can develop ulcers are direct or topical irritation of the gastric epithelium and systemic inhibition of endogenous mucosal prostaglandin synthesis. The acidic properties of most of the NSAIDs also contribute to the disease in developing topical injury of gastric tract. Aspirin is one of the agents that have a greater efficacy in causing topical irritant effect. Cyclooxygenase 1 or COX-1, and cyclooxygenase 2 or COX-2. These are isoforms of COX, in which COX-1 is found in stomach, kidney, intestine, and platelets. Whereas, COX-2 is undetectable in normal physiologic conditions, meaning that its presence is observed during acute inflammation and arthritis. COX-1 produces prostaglandin, an important inflammatory mediator, serves in gastric protection, regulate physiologic processes such as GI mucosal integrity, platelet homeostasis, and renal function. COX-2 also produces prostaglandin that is involved in fever, pain, and inflammation. Okay, that's a pretty tricky movie, right? But what do NSAIDs perform in the act? NSAIDs constitutes as two forms, selective and non-selective forms. The non-selective forms inhibit both COX-1 and COX-2. So, as stated before, inhibiting COX-1 could produce a reduced or a declined effect of prostaglandins, eventually exposing the gastric layer or gastric mucosa to a higher acid output. But in selective forms, drugs such as celecoxib inhibits only COX-2, without any significant effect on prostaglandins derived from COX-1. COX-1 to COX-2 inhibitory ratio determines the relative GI toxicity of a specific NSAID. Standing with chronic PUD, a life-threatening complication usually manifests with upper GI bleeding, perforation and obstruction that are causally associated with H. pylori invasion and NSAIDs usage. At any of the instances, down the line, bleeding is the key manifestation that can be seen with the erosion of an ulcer into an artery. It may be occult and insidious or may present as melena, black-colored stools, or hematemesis, vomiting of blood. Ulcer-related perforation into the peritoneal cavity is generally considered a surgical emergency. Most patients experience ulcer symptoms prior to perforation. Penetration could be another risky event, where the ulcer burrows into an adjacent structure, pancreas, biliary tract, or liver, rather than opening freely into a cavity. Gastric outlet obstruction is related to mechanical obstruction caused by scarring, muscular spasm, or edema of the duodenal bulb, usually resulting from chronic ulceration. With an overall aspect, peptic ulcer disease clinically manifested as abdominal pain that is often epigastric. A typical nocturnal pain that awakens the patient from sleep, especially between 12 a.m. and 3 a.m. Heartburn, belching, and bloating often accompany the pain. Nausea, vomiting, and anorexia are more common for patients with gastric ulcer than with duodenal ulcer. Possible laboratory investigations for PUD are fiberoptic upper endoscopy, also known as esophagogastroduodenoscopy, detects more than 90% of peptic ulcers and permits direct inspection, biopsy, visualization of superficial erosions, and sites of active bleeding. Upper gastrointestinal radiography with barium has been replaced with upper endoscopy as the diagnostic procedure of choice for suspected peptic ulcer. Usually treatment will involve killing the H. pylori bacterium if present, eliminating or reducing use of NSAIDs if possible, and helping your ulcer to heal with medication. Antibiotics to kill the bacterium, such as amoxicillin, clarithromycin, metronidazole, levofloxacin. Proton pump inhibitors, also called PPIs, reduce stomach acid by blocking the action of the parts of cells that produce acid. These drugs include the prescription and over-the-counter medications omeprazole, lansoprazole, rabeprazole, and pantoprazole. Acid blockers, also called histamine, H2 blockers, reduce the amount of stomach acid released into your digestive tract, which relieves ulcer pain and encourages healing. These include the medications famotidine, cimetidine, and nizatidine. Antacids that neutralize stomach acid. Medications that protect the lining of your stomach and small intestine, such as sucralfate and misoprostol. Lifestyle modifications include: patients with PUD should eliminate or reduce psychological stress, cigarette smoking, and the use of non-selective NSAIDs, including aspirin. If possible, alternative agents such as acetaminophen, a non-acetylated salicylate, example salsalate, or a COX-2 selective inhibitor should be used for pain relief. Although there is no need for a special diet, patients should avoid foods and beverages that cause dyspepsia or exacerbate ulcer symptoms, example spicy foods, caffeine, alcohol.